Well, I wanted to thank you all so much for giving me the opportunity to share my project with you. And I've learned that it's been brought to my attention that I already need to be more careful here with my language in my title slide here. So I'm going to present my project to you on interdisciplinary telehealth assessment of gross motor development in infants at high likelihood for ASD. And I'm a physical therapist, and I'm one of the medium-term LEND trainees. And this is my funding acknowledgement and disclaimer slide for both the LEND program and the TEDI study, which this was a part of, which you'll hear about a little bit later. So there's a good amount of evidence to suggest that gross and fine motor delays or impairments have been noted in infants with or at higher likelihood for ASD, and that some of these motor deficits may persist into childhood and adulthood. And while motor impairments are not a core feature of autism, they can interfere with and impede cognitive, language, and social emotional development and abilities. And later in childhood and adulthood may affect participation in sports or activities that one, facilitate social interaction, and two, provide opportunities for aerobic exercise that are beneficial for both physical and mental health. But despite the influence of motor impairments on other domains, language, behavioral, and social concerns often take precedence in terms of parental concern, which is very understandable, but why I think it's important to have PT involved early in the screening and assessment process to help pick up on the subtleties of how motor skills are performed, how they may be affecting other domains, because we're not, as PTs, we're not just looking at whether a milestone is met or not, but we're looking at the quality with which that movement is performed and the preferential movement patterns that a child is using, and the subsequent potential impact on other domains. So just a quick example is, parents may say, oh, my child hates being on her tummy, but that's okay because she can play sitting up now, or he can crawl, but he really prefers to scoot or walk. But to us, the prone progression is a really important precursor, or it's a really important progression, and it's can be a really important precursor to fine motor skill development. Well, it can be a precursor to a lot of things, including fine motor skill development and including handwriting, a precursor to visual development, sensory integration, core and limb strengthening, and inner limb coordination, which can all really affect how a child explores their environment and interacts with others in that environment. So that's kind of the background of why this topic was important to me. And the second part of that is we know that early screening, assessment, and intervention are crucial for improving outcomes for children with ASD. And ideally, these services would be provided by a coordinated multidisciplinary team like at the Mind Institute. And often such teams are found at university and hospital centers, but we know that the need for these services extends beyond the geographic reach of these centers. So how do we bring high quality interdisciplinary care to families who don't live near one of these centers? And Amy set us up really well for this. So one proposed solution is telehealth, which is also very timely right now with the COVID-19 crisis. So I knew when I was developing this project that researchers at the Mind were working on various telehealth models for assessment and intervention. And for this project, I wanted to know if and how PT might be able to fit in to those models. So I was very fortunate that Megan Talbot and Sarah Dufek were launching their TEDI study as I was beginning to design my project. And in this study, they're refining and piloting a parent-implemented telehealth assessment of social communication for infants 6 to 12 months at higher likelihood for ASD. And they are recruiting infants who are demonstrating early social communication concerns from Baby Steps, which is the high-risk infant follow-up clinic at UC Davis, from various Mind Institutes, from the Mind Institute and various recruitment tools that are associated, and from the Alta Regional Center. So the first objective of my project was to determine the feasibility of administering a remote observational gross motor assessment within the context of a telehealth assessment of social communication for infants 6 to 12 months at higher likelihood for autism spectrum disorders. And I hypothesized that it would be feasible to obtain a composite AIMS score in at least 70% of the cases. And the AIMS, which I'll explain in a minute, is the assessment that I chose to use for this project. And then my second objective was to determine the inter-rater reliability of the AIMS collected via a telehealth assessment in these infants. And I hypothesized that the inter-rater reliability administered in this format would be high. So the first thing I had to do was to find a tool suitable for telehealth, and I settled on, or chose the Alberta Infant Motor Scale, or the AIMS. And I chose this measure because it assesses gross motor development for infants 0 to 18 months, so it fit the age range that we were studying well. It's purely observational. It's easy to score. It looks pretty simply at whether or not a skill performed a certain way is present or absent. So it also does take into account the quality of the movement, which is another feature. And then this measure has been well established in the literature, and it's been recently validated when administered and scored through the submission of home videos, suggesting that it would be a feasible measure to obtain within our telehealth assessment. So in terms of our methods, they are still ongoing, but we first had to incorporate the gross motor assessment into the existing protocol, knowing that the sessions would be led by the TEDI investigators. And then we are collecting AIMS data for 10 to 15 infants, ages 6 to 12 months, at higher likelihood for ASD, so whose parents have shown early social communication concerns. And then following reliability training, which we did at the beginning of the project, 2 licensed PTs are scoring the AIMS independently from video. So they were administered in the telehealth session, but scored afterwards. One of the raters, Katrine Mattern-Baxter, who is on this call, has 30+ years of experience, including pediatrics. And I have 13 years of experience as a PT, but less than 1 year in pediatrics. And then for outcomes, we are going to document the ability to complete this assessment via telehealth, noting areas of difficulty, and to calculate the interclass correlation coefficient to determine inter-rater reliability. So short, unstructured floor play sessions were already planned in the TEDI protocol, so we were able to build off of that and create a more semi-structured floor play session. And since the sessions were run by another investigator, we created this flow chart to help guide the floor play sessions so that we as PTs could make the most of that assessment time, hopefully without burdening the investigator running the rest of the assessment. All right, so after a couple iterations of that checklist that we just showed you, or that I just showed you, we were able to include 2 5 to 10 minute sessions of semi-structured floor play within the existing TEDI protocol, and kept the whole assessment within 60 minutes, which was long but doable for most of the families. We've run 4 assessments so far, and Katrine and I were able to fully score all 4 of those assessments. Some common areas of difficulty were, as you can imagine, trying to adjust the camera angle and the distance and position to make sure that both investigators could see what we needed to see, so close enough that we could see facial expression and communication between the child and the caregiver, but far enough away that the child could move around and interact with their environment, and that we as PTs could see their whole body. And then, there's some issues with cueing. A lot of the parents, in an effort to keep their child on camera, would actually restrict their movement. And so, we found it, Megan did a really great job of trying to cue for allowing some of that movement sometimes, but even still the families or the caregivers would still restrict their movement. And so I wonder, there were a couple of times where both Katrine and I felt like if we could cue the parents a little bit more, we might be able to see some more of their motor skills. All right, so in this slide here, we're looking at the ICC values And you can see that for the total score and in the prone, sitting, and, or excuse me, prone and standing subscales, we were highly reliable, and that was statistically significant. Not quite so good in the sitting subscale, and that was not statistically significant. And I think a lot of this, at least at this moment, was driven by a larger difference for just one child. And so it will be interesting to see if the discrepancy continues as we test the rest of the participants and we have more difficulty in the sitting position, or if it's just related to that one case. So in conclusion, we were able to successfully implement an interdisciplinary telehealth assessment of gross motor skills. It was a lot actually easier than I expected. And we have good inter-rater reliability in this preliminary sample. Our limitations, at least so far, is that it's a very small sample. And as I mentioned, I do wonder if sometimes, I do wonder about the validity of the measurement. We're pretty reliable, but parents were often restricting their child in such a way that I'm not sure we actually saw the full range of their ability. So our next steps would be to finish collecting, scoring, and analyzing reliability for this cohort. And then it would be good to examine specific areas of disagreement between the raters before finalizing our scores. I would also like to consider the impact of having a PT rater live or on the call to maybe cue for those extra motor skills that might have looked restricted to us, and look a little bit more into the validity of the measure. I think later the TEDI study may also be collecting at least parental report of gross motor skills, so it would be interesting to compare, how our ratings compare with that, and eventually, maybe even against a live rater in person. And then it would be nice to determine the degree or characteristics of gross motor delays present in this cohort and investigate the relationship between gross motor delays and other social communication skills and outcomes. So I want to give special thanks to Katrine Mattern-Baxter, who mentored me throughout this project and was my second rater, and to Megan Talbot, who was open to and excited about adding the motor component to the TEDI visits, and who was very helpful and instrumental in facilitating many logistical components in completing this project. And I also want to thank Aubin, Kelly, Janice, and the whole LEN team for this amazing experience.